So, good afternoon. I'm Jennifer Buczyner. I am going to be giving you a talk on myasthenia gravis. I'm a general neurologist practicing in Palm Beach Gardens, Florida, and a member of First Choice Neurology. I'm just going to give it a minute before I get started. If you tuned into my migraine lecture a couple weeks ago, you'll see that this one is a little more technologically advanced. So I've tried to entertain myself and others during this time with learning something new every day. So I have to give a shout out to my husband, Michael Buczyner, who's an investigative reporter, if you didn't know that, who has helped me set up this super complicated OBS live Facebook live stream. I have no idea how to do any of this, so don't ask me to do it again. But, you know, trying to learn something and make it interesting every day. So I'm going to go ahead and get started. And we're going to talk about myasthenia gravis, which some of you may be familiar with. Feel free to interrupt me. I'm doing my best to try to pay attention to the comments too, but if you saw my setup here, it's kind of complicated to pay attention to all of this. So we're going to switch gears and talk a little more about myasthenia gravis once I get the right screen up. So if you're not familiar with myasthenia gravis, it's an autoimmune neuromuscular disorder that's characterized by fluctuating weakness of voluntary muscle groups. The presenting symptoms include a droopy eyelid that we call ptosis, double vision, which is called diplopia, dysarthria, difficulty swallowing, also called dysphagia, respiratory distress called dyspnea, fatigue, and generalized weakness. The prevalence of myasthenia is 20 per 100,000, but it's probably underdiagnosed and it's likely much higher. And it occurs regardless of race, age, or gender. So, what do I hope you learn at the end of this lecture? Well, hopefully by the end of this, you'll learn what myasthenia gravis actually is, who is at risk for myasthenia gravis. So again, we know that it doesn't really matter what age, your sex, your gender, your race. What are the symptoms of myasthenia gravis? Could you know somebody who maybe had myasthenia gravis, or maybe they don't even know that they have it? And hopefully I'll go through how it is diagnosed, and we'll go through some of the current treatments. So I'm going to switch gears and switch back to my camera here for a second and just kind of reintroduce myself as I realize there's more and more people coming on during this. But again, I'm Jennifer Buczyner. I'm a general neurologist practicing in the Palm Beach Gardens area. Just to give you my background, I actually did a neuromuscular fellowship and neurophysiology fellowship at Emory, where I trained with some of the premier neuromuscular specialists in the country, including today we're talking about myasthenia gravis and Michael Benatar, who I think his name comes up in one of the papers that I'm going to show you briefly. I realize that you guys are not neurologists or scientists, so I'm going to try to make this as simple as you can to hopefully teach you something that you don't know a lot about. And if I pull off this technology, I think my husband will be super impressed. And just to tell you, there's a little joke and contest in some of the people in our company as to whether, you know, who can give the best presentation. So I'm trying to make it interesting with props and whatnot. So let's see what I can do. All right, so if you're not familiar, you have what we call a neuromuscular junction in your body. And this is kind of where the nerve gets the signals to tell the muscles to move. So on the left side of the picture, you see what we call an axon, which is a nerve axon. And at the bottom, you see the muscle. So in a normal muscle, what happens is there is a chemical signal that is propagated throughout the axon and ends up getting to the nerve terminal where a chemical called acetylcholine is released. And that chemical then tells the muscle what to do to move. So in myasthenia gravis, which we're going to talk about on the right side, what happens is there's destruction of that chemical called acetylcholine, and that is due to multiple factors, which we'll go through, but one of the most common being an antibody to the receptor where we process acetylcholine. And so all of the symptoms that I just went through are typical symptoms one would see in myasthenia gravis. These pictures get a little more complicated. It probably will give some of you nightmares, so I'm going to just keep it super simple. So if I'm looking again at this picture, this is exactly what we just talked about. There's something called an action potential, which several of you probably have nightmares about. But basically what happens is there's a bunch of different chemical reactions in the neuron, and that releases acetylcholine, like we said. And acetylcholine makes your muscles move. So when you look to the right side of the picture, what happens is these receptors where we process that chemical can cluster. There's also two other antibodies, if you see on the bottom right where it says MuSK and LRP4, that are also important in processing acetylcholine. And so myasthenia really involves destruction or basically antibody development to any of these that affects how it's processed. And looking just at this picture again, this is kind of showing the exact same thing, but there's three different mechanisms that I'm not going to belabor, but basically three different mechanisms that we think causes myasthenia. So first of all, there's something called the thymus gland, and that's on the top left. And in some patients with myasthenia, they develop something called a thymoma, which I'll talk a little bit more about, which is what's thought to produce some of these antibodies. On the left side of your screen, you see something called complement. We know that complement helps us get rid of toxins and things that aren't supposed to be in the body. And when it is activated in something like myasthenia gravis, it will cause destruction at that nerve and muscle junction. We also know that many people, the majority of people, have antibodies, as you see in number 3, to acetylcholine. And number 2, where it says antigenic modulation, are where you have a receptor that, an antibody that cross-binds the receptors and internalizes them and degrades. So myasthenia is basically a disease with multiple different mechanisms. This is the last picture, I promise, that's scientific, but essentially just showing what we call an electron microscopy picture of the same exact thing we've been through. So on the top, you see a normal muscle, and in the top right, the black and white picture, you see muscle contracting and these pretty folds with acetylcholine in it. On the bottom, in myasthenia gravis, you see that the signal is blocked and there is destruction of the membrane. So I see that someone just asked, is this the same as with MuSK? So I'm just going to go back and show this picture one more time. MuSK is on the right side of the picture. It's right next to where it says AChR clustering, and you can see the MuSK antibody. So yes, MuSK is one of the many antibodies that I will get to in a little bit. So I'm going to switch back over to me and just try to have something more to say. So you can see myasthenia is kind of the prototypical autoimmune disorder, and I tell people if anyone wants to go into medicine and they find myasthenia to be uninteresting, or if they find they want to be a neurologist and this is uninteresting, this is really one of the oldest and most prototypical autoimmune diseases. And what's really cool is how it was identified and how a treatment was identified. So when you see people with myasthenia, we can kind of figure out by their age what antibody they may have and what disease-specific findings they may have. And so looking here, what you can see is that when someone has this early, and by early we're saying less than 50, that they likely will have anti-acetylcholine antibody, and they'll probably have generalized disease. And then we'll talk a little bit more about their thymus and what role the thymus, that gland, plays. And then you can see in later onset, it's they're going to less likely have a thymus issue. Some people have little tumors called thymomas. That's about 10% of patients. And then, as we said, someone just asked about MuSK, and that's about 1 to 10% of patients as well. And that presentation is different. Typically, we describe it as what we call bulbar, and same with LRP4. And so this would be more of a presentation affecting the throat, the swallow, the breathing, things along those lines. And very few patients have what we call a seronegative presentation, which means despite everything we do, we think they have myasthenia gravis, but we can't prove it in an antibody. And then lastly, there are some patients who have what we call ocular-only disease, where they only have a droopy eyelid. All right, so we're going to switch gears and talk about diagnosis, and this is definitely more of an interesting part. So if you are diagnosed with myasthenia, you can feel free to comment how you were diagnosed. But when I was in medical school, and I'll date myself here just a little bit, tensilon test is something that we all learn about, and the reality is I saw it one time in my life. Reason being, it actually can cause bradycardia, and you can actually have to give somebody an atropine injection to bring their heart rate back up. So it's not something that's done so commonly, but the one time I did see it, the person basically had a cardiac event and had to be taken to the hospital. So not something that we use so much anymore. The Icepack test, which I'll tell you I used as recently as a couple weeks ago. We'll just briefly talk about electrodiagnostic testing, which hasn't really evolved much in the last couple hundred years. And then I'll go through some of the antibody testing that's available. And this is just looking at the sensitivity and specificity. If you've never heard those terms, I'm sure that you have now with all of the antibody testing for COVID. But basically, at the end of the day, all of these things vary in terms of how frequently they pick up a positive test and how frequently there can be a false positive or false negative. Okay, so what I imagine some of you probably don't know is that dogs actually can get myasthenia too. So I'm going to describe what we see here. So this is a dog with Myasthenia Gravis, okay? So you can see on the left that their lid is blinking. That's something we call a Kogan's lid twitch. And the dog is going to be given Tensilon. So as I said, humans, we don't really do this, but for some reason, dogs are okay. So you saw that dog was blinking. Very cute, by the way. And now when they come back, in just a second, you'll see that the dog no longer blinks or has that Kogan lid twitch on the left side. I have a more impressive example to show you after if I can't convince you just based on the lid twitch alone. So you see that twitch that you saw where the lid kind of made an extra twitch no longer is there. Obviously, a dog's probably not the most compliant patient that we have.
Looks like that.
But now I'm going to switch gears and show you this golden retriever, and you can look and see how the golden retriever walks. So obviously very weak. It's typically more of a proximal weakness.
Poor guy.
And his voice could record it.
Hey, my old buddy Gavin Brown is on Thanksgiving. It's also Gavin Brown's birthday. He sees more myasthenia than me. Alright, so now this dog is going to get Tensilon.
I heard. That's great.
I can get back and forth. Not, I mean, over like 5 seconds. Not a...
And so again, you have this dog who had fluctuating weakness, I'm sure was interfering with their ability to function and be happy. And what you'll notice after the dog gets the Tensilon is how happy they become. You see the tail wag and all. So it's a really impressive thing. Like I said, it's free because it's a quick fix. So you see how happy the dog is, wagging his tail. So I think everybody gets the point.
Yay.
Up, hang tight. All right, and then this is the Icepack test. So the Icepack test is something that I like to use. I call it the cheap man's test. I actually use it a lot in my office. I used it a couple weeks ago. But basically what you do is if someone has an observable droopy eyelid, so you can see that the patient's left eye is very droopy, you put an ice pack over it for 2 to 5 minutes and you're looking to see if it improves. And the reason we know that this works is because cooling improves neuromuscular transmission. So I had a lady a couple weeks ago who had difficulty swallowing. She also had a droopy eyelid. She had seen probably 15 specialists. And for whatever reason, everyone just kept telling her, oh, you've got a droopy eyelid, you're getting older, maybe you'll get an eyelid lift surgery or something like that when you get a facelift, which she did not need any of that. But while we're talking about her swallow problem, I asked her about her eye. I actually had her show me an old photo ID, her driver's license, and it looked like it wasn't there. So I said, let's give it a shot. We took out an ice pack, and lo and behold, her droopy eyelid totally opened. So I'm going to switch gears and talk about electrodiagnostic studies. And everyone always says to me when I see them as a patient in the office, like, well, how do I know if I've had a nerve conduction study before? So if any of you have ever had a nerve conduction study, you will never forget having it. It involves shocks and needles. And so the tests that we do, or one of the tests we do specifically for myasthenia gravis, you definitely will not forget, because what we do is give you exactly what it says, repetitive nerve stimulation at a low frequency between 1 and 5 hertz. And what we see is this characteristic pattern you see on the left, which is what we call a U-shaped curve. And the reason that happens is, remember we talked about those clefts with all the acetylcholine, and those become depleted. And so there's less and less available. So if you look on the right side of the picture, you see that in a normal patient, we don't deplete that. But in myasthenia gravis, that goes down over time. Here's a picture showing the same thing. On the left, you see a normal response, and you don't see that U shape. And on the right, you see what we call decrement, or the U-shaped curve that we see in myasthenia. On the right side, I also included a picture. I think I told you at the beginning that how we diagnose this hasn't really evolved in the last 2 years. But back in the day, people were probably tied down. So you can see this lady. It looks very archaic how it's done. Hopefully we make it a little bit better of an experience, but it's about the same as it was. So switching gears to the antibodies. The acetylcholine receptor antibody is the most specific test. If it's positive, we don't do anything else. So again, how often do we see this? Well, about 85% of generalized myasthenia. And depending on what source you read, you may read higher or lower. I've seen anywhere from 60 to 85. And then in people with just ocular symptoms, we see it about 50% of the time. The other ones I mentioned as well would be MuSK, LRP4, and seronegative myasthenia. And so in 2016, there was a consensus guideline that was put together on the management of myasthenia gravis. And what I think a lot of people don't know is that even though there are these international guidelines, the thing is there's not much agreement, and you'd be surprised how many neurologists may or may not even feel comfortable with the subject matter. You can see the authors on the left, and for those of you watching in Florida, Michael Benatar is at University of Miami, and he was at Emory when I was there. So he's my go-to in Florida if I need another opinion. So what's the thymus anyways? So is anybody familiar here with the thymus gland? Feel free to comment if you know anything that the thymus actually does. I like to say it's kind of like the appendix. It really doesn't do a whole lot once you get in adulthood. And so it's a small gland that lies in front of the chest. And really in developing our immune system early, it's important. So you can see that a baby's thymus weighs between 0.7 and 1.1 ounces. And by puberty, that doubles in size. 10 to 15% of patients with myasthenia gravis have a thymoma, and another 60% have what we call thymic hyperplasia. So how is this figured out? Well, in the early 1900s, surgeons, for whatever reason, started removing people's thymus and then realized incidentally that that resulted in improvement in their myasthenia gravis. So now, this can actually be done either transcervically or, in a more open procedure to remove the thymus gland. And there's evidence, even in the New England Journal of Medicine, an article was published a couple years ago that says that the long-term effects of removing a thymus gland, if you're under the age of 60 or 65, are significantly better than just medical management alone. So this is a really confusing algorithm for treatment, and I'm going to go through this maybe without back on the camera and see if I can do it that way here. No, I can't, because then I can't show it to all of you. Okay, so at the end of the day, treatment involves a bunch of different things, and you really want to make sure you're seeing a doctor who knows what they're doing. So if you just have what we call ocular disease, then you really only need to be on a medicine that we call pyridostigmine or Mastodon. If that isn't cutting it, then you may want to add a little prednisone. If you've got generalized disease and you have an antibody that we talked about, then your doctor may talk to you about a thymectomy. If you've got generalized disease and you don't have an antibody, the question is, should we check you for other antibodies? And then, we may want to put you on immune suppressants. So I just got a question are myasthenia gravis patients at higher risk with COVID? And so what I would tell you is that if you're on any number of immunosuppressants, just like anything else, you're at higher risk. So it really depends on the medication that you're on. Obviously, these patients are at risk of respiratory issues, and that is one of the symptoms that we're seeing in COVID. So they're definitely more at risk than say, the general population if they're on an immunosuppressive agent. Last treatment I'm going to mention is that I talked briefly about pyridostigmine or Mastodon, which was the only FDA-approved drug until October of 2017. And this is Soliris or eculizumab, and it was approved in October of 2017. The Mastodon was approved in the 1960s. And this affects complement. So if you remember at the very beginning of the lecture, I talked about complement being a role or a mechanism for myasthenia gravis. And so the thought is if we can prevent destruction at the neuromuscular junction, and affect one more mechanism of myasthenia gravis, perhaps patients will do much better. So I have many patients on this and have had a good response. And there's a lot more complement inhibitors and complement-involved medications in the pipeline. And so at the end of it, and I think any patient with myasthenia would probably tell you this, is many times they're dissatisfied with their current treatments. They're still having symptoms. They feel frustrated. They feel that this is basically putting their life on hold. And if any of you have ever been on prednisone, I mean, I have people who refuse to go on it even for 2 or 3 days for other indications. So imagine a lifelong, being on prednisone lifelong. So all of our medications, put people at risk, whether it's immunosuppressing them and turning off their immune system. And so this is a disorder that can really impact quality of life. So before I have 2 patients. I'm trying to keep it a little more lively and interesting. So before I get to the patient interviews, feel free, I can answer questions for a minute if you like. And then I'm going to basically post 2 interviews from patients that I have about their symptoms and experience with myasthenia. Both have actually done great. And what the take-home point should be is, one, I had a attending in medical school or residency, and his first thing that he always taught us was, one, to always reevaluate the diagnosis that somebody made and how they got to their diagnosis. So whenever I see somebody, I don't care who it is and who diagnosed them, the first thing I usually ask them is when the diagnosis was made and how it was made. And 1, you learn a whole lot from that, and 2, it's really interesting, and sometimes you may not always agree with the diagnosis and how they got to that diagnosis. The other thing is you'll also learn how a lot of these patients, their lives really are affected. The first patient, you're going to learn what she's been looking forward to do for 10 years and is very hopeful that she's finally able to do it. And the second patient, what I would say about him is that his course is a little bit different in that he, after diagnosis, he was extremely, extremely sick and required acute treatment very rapidly. And now he's at a very good place. So what I would tell people who are newly diagnosed and it seems like their life is turned upside down is that, if you get on good treatment and if you have a doctor who's kind of helping guide the ship, you can do really well with this diagnosis. All right, so here is our first patient. And this is Lorraine. Lorraine, she's had myasthenia for how many years?
Since 2009.
2009. Tell me what symptoms you had when it started.
First, before I was diagnosed in 2009, in 2007 and 8, I was always vertigo. Okay, so I don't know. I was always walking to my left.
Were you having double vision?
Mm-hmm.
Okay.
And felt like I wanted to fall.
Uh-huh.
And I was always having problems breathing. It seemed like my lungs were not expanding. Okay. And I went to all these different doctors. They thought I had lupus.
Got it.
They tested me for rheumatoid arthritis. And at one point I went to therapy. And I continued the therapy because I thought I was losing my mind. And one particular day, I was trying to eat, and the fork fell out of my hand. I couldn't grip it. I couldn't pick it back up.
Why did they tell you there was nothing more you could do?
I don't know. Someone told me, say, now, go see a neurologist. So when they started testing me for that, they said, you had myasthenia gravis. And I go, well, what is myasthenia gravis? And in between all that, I had problems swallowing.
Yeah.
Okay. And I just couldn't hold spit.
Yeah.
I was always drooling. And
how many times have you been hospitalized for your myasthenia?
I say maybe a 6
Tell me
times.
what you've been doing most recently to treat your myasthenia.
What have I been doing?
Yeah.
To maintain myasthenia? I pray a lot. But
what about your medicine?
At times I take more of the medicine. We tried medicine, Imaron.
Didn't work.
It didn't work.
Prednisone?
Cereset didn't work. And I have to fight the insurance on Cereset because they said that it was a no-nonsense drug for what I had, in other words.
Prednisone?
Prednisone seems to have made me worse. The weakness.
IVIG?
IVIG worked for a while, but then only for maybe about, maybe about 6 years.
And how about plasma exchange? Plasma exchange.
Plasma exchange, I find that to be good, but it's really, it limits me to everything. I can't travel as far, I can't do, because I'm always in for treatment, I can't.
How do you feel now about starting it?
I feel great because then I met you and you specialize in myasthenia gravis. There are 2 people in the state of Florida. Like I said, there was one in Sarasota, and I forget where the other guy was. He was up,
The guy in Miami, Michael Benatar. Yeah.
And I said, well, I spend too much time in my car, trying to get to these places.
And you take care of your twins, right? Of your grandkids.
Yeah, well, yes. And then at first, when they were born, they were so small, I had to be careful how I picked them up because I had so much weakness. I always had to have somebody in the house with me, with them. And feeding and holding them. Church members would come by and make sure, that they were fed and changed, and me and my husband.
Yeah. So if this medicine works for you, what are you most excited to do with your
What I want to do?
Yeah.
I want to swim.
Why do you like swimming so much? I love that.
I want to submerge.
Okay. And you haven't been able to do that.
I haven't submerged, and I'm born and raised here, and that's my life. Swimming, pool, so much water.
Okay.
And I have grandkids, so I have to sit and watch them, and
so we got you vaccinated for meningitis. So hopefully we're going to get you started in like 2 weeks,
Okay,
right?
yeah.
And you're going to give me 12 weeks.
And that was one of the
I'm just going to chime in here. I think she's good here. So Lorraine actually just started one of the newest treatments that I mentioned, Solaris, and I had promised her that if she gives me 12 weeks, I will do my best to make sure that she is back swimming. But if you notice from her exam, she had a droopy eyelid, her left eye was turned out, her speech is, dysarthric at times or slurred at times, and she's had a pretty aggressive course. So if you're not familiar with all those medications she's been on, she's basically been through the gamut of everything, and I would say that she falls into the category of what we call refractory myasthenia, and she really only responds to plasma exchange, which, if you're not familiar with it, for the most part is done either in a hospital or in a very specialized outpatient setting, and it's a 10-day admission, and she takes care of her grandchildren, and obviously this really impacts her life. So hopeful that a different treatment can offer her, many other options. Okay, so we're going to switch back to the second patient I have for you here. Hopefully this is helpful for all of you. And I think some of the questions that I've gotten, that I've seen, have been on the purpose of being on medication. And what I would tell you is no doctor really wants to keep patients on prednisone. So the goal is that we get you off of that. The majority of other treatments that we have require several months, usually 8 to 10 months to be effective, unless it's IVIG or plasma exchange. Okay, so we're going to go to our next patient. This is Mr. Doria. And if you start out on the side, I'll own it and say this was my technical difficulty, or I could say it was my attempt to make you feel like what it is to feel like someone with myasthenia and see upside down or sideways or double.
All right, so we have Mr. Doria here, and he's had
Whoop, hang on.
All right, so we have Mr. Doria here, and he's had myasthenia for how long now?
Since October. Since September of last year.
Okay, so since September of last year. And tell me what symptoms you had when it started.
Well, I used to have a tired body, all my necks. I have a little pain in my neck. I just try to take a rest. Sometimes I have cramps in my hands, in my foot, and then I just started to get tired when I try to eat something. I choose, I nap. Sometimes I get a time in a few minutes. I cannot eat nothing. Even I cannot drink. I can really something happen to me. I cannot swallow. Just all my food was in my mouth. I try to chew, moving my yeah. And then I cannot eat and I cannot swallow.
And your primary care doctor thought right away you had myasthenia and tested you, right?
Yeah, I went to my doctor because I changed my, that's what you have now.
Yeah, and then you saw me, and if I remember, right away I said you needed to get IVIG, right?
Yeah, I mean, here, I was suffering, I was nervous, because one of the things he said me to do, we have to check your chest gland in the bone.
CT of your chest.
If you have some problem over there, doesn't mean, you have to get surgery or operate the things. Because I want to know, right away what happened to me.
So that was Mr. Doria, and what I would tell you about him is that it was pretty crazy. His swallow was so impacted, he developed a severe pneumonia, and he actually required a feeding tube temporarily. And this was right at the presentation of his disease, and he has done beautifully. I mean, really, if you examine him now, he has very little in the way of symptoms of myasthenia gravis. He's doing great. And so I think just to also throw out there that there is definitely hope if you're newly diagnosed. I know I saw someone on here that was. So I'm going to kind of move on into the next slide, and I'm going to answer, I see a question or two here. So once a patient has a thymectomy, are the chances high of needing IVIG ever again or having episodes from time to time? So we know that getting a thymectomy in patients, particularly patients your age, will basically reduce the severity of disease. Our hope when we see any patient is to put them into a remission or what we call minimal disease manifestation. But there's really no guarantee. We neurologists always like to say no one has a crystal ball because none of us really know whether or not that is the case. But I can tell you, and specifically Brittany, if you want to look, there's a New England Journal of Medicine article, I want to say it's 2017 or 2016, that actually looks at several hundred patients who got a thymectomy or just got prednisone, and they do significantly better, particularly the earlier that they do it after diagnosis. And there's a better chance to go into a clinical remission. Okay. All right, so one thing I just kind of wanted to mention is that many medications worsen myasthenia symptoms. I make sure to talk to all of my patients about this. It's really important that you know this. As I said, there's many doctors who are not super familiar with myasthenia gravis. Just remember, it's an ultra rare disease. And, for example, people don't always think about it. I mean, if you're going for any kind of surgery and getting any kind of anesthesia, it's important they know that. If you have an infection, there's antibiotics that can worsen your myasthenia. One thing a lot of women out there get upset over is when they have myasthenia gravis, you can't get Botox injections because Botox works at the exact same place on acetylcholine. Corticosteroids. So sometimes steroids, in particular, when you first start them, will actually worsen your myasthenia gravis. So there's a list available on the Myasthenia Gravis Foundation Association website or the MGFA, and I recommend that everybody print those out and give them to their other doctors, their non-neurology doctors. Okay, so I'm going to make this a little more interesting. And we're going to switch gears and try to talk about famous people with myasthenia gravis. So it's sort of more of a game. And basically, neurologists, because we have nothing else to talk about, we like to note or comment on famous people who had certain diseases. So if any of you know who this famous person is, I will tell you that they had myasthenia gravis. Please feel free to comment if you know who it is. And then basically what we will do is I'm gonna show it here, but I haven't seen anybody's comment that they know who this one is, so I'll go ahead and do it. So this is Laurence Olivier. He was an English actor, producer, and director. And he had myasthenia gravis for 22 years of his life and died of renal failure at the age of 82. Here's another famous person with myasthenia gravis. Anybody know who this one is? All right. This is Stephen Garrett. He was in a band Playa. He was a songwriter for a few artists. Here's all of them if you'd like to know. And basically his death was kind of a mystery because it sounds like he ended up dying from something that wasn't really myasthenia gravis, though he was diagnosed with myasthenia gravis at the time of his death and died soon after that. Here's the last one. So probably many of you may be familiar with this one, or you may not realize it when you see his picture. But this is Christopher Robin. So if you're a Disney fan, Winnie the Pooh. This is the Christopher Robin who was in Winnie the Pooh. And he had myasthenia gravis and died in his sleep in the 1990s. Okay, so I'm getting close to the end here, and I just want to go through some pearls for myasthenia gravis patients. And so what I would say at the end of this is make sure that you have an experienced neuromuscular specialist or neurologist who is familiar with treating MG. Like I said, this is an extremely rare disease. Some people, for whatever reason, it's just not their area and maybe not something they're comfortable with. And myasthenics can get very sick and can be, hard to take care of. So make sure whoever you're seeing is comfortable with it and comfortable managing it, because it's important that you have that relationship and they know when to kind of pull the trigger and when to be available to you. Make sure that you work closely with your primary care clinician as well. It's important that you follow with them for lab testing and follow-up results. And if you know from Mr. Doria, it was actually the primary care doctor that made the diagnosis. So many times they're familiar with this too, and many times they may not be familiar. And if they don't know that you're being treated for this and go to put you on a medication that they may not be aware has an interaction, you can end up, worse off. Make sure that you're adherent to treatment. And so what that means is make sure that you're actually taking your medications, make sure that you're aware of the adverse events, and make sure that you know when to call your doctor. It's important that you also stay active, but don't overdo it. And then anytime you have an infection, infections in any condition in neurology can always make any neurologic diagnosis worse and can cause an exacerbation. So it's important that you kind of stay on top of that. This is kind of what I just went through. See. And I wanted to throw up there the Myasthenia Gravis Foundation of America website. The MGFA provides resources to patients. The list of the drugs to avoid is up there as well. I also wanted to throw out there, if you have been following me on social media, you'll see that my staff, kind of during all this, we started a glove and mask company. It's www.infectiousolutions.com. The profits from this company are going to my staff during these times, but also a large chunk is going to the MGFA because they provide great resources to myasthenia gravis patients. Here is a lovely picture of me if you have not seen enough of me today. My office number, and just to kind of tell you, I'm a partner in a large company, First Choice Neurology. First Choice is the largest neurology private practice in the United States. We have many providers throughout the state of Florida. And obviously this has been an extremely difficult time for all of us to kind of navigate as healthcare professionals, how to kind of navigate the scene, run a business, and make sure we stay relevant to both our patients and stay safe at the same time. So I want to give a shout out to everybody in the administration and in the central business office for organizing these Facebook lectures. I think they're great. Somehow somebody liked me enough to come and do a second one. But two, they've just really helped navigate the path. If you've been on any of the virtual visits, I know that there's frustration sometimes among patients, and truthfully, there's frustrations among the doctors too. It's not a perfect thing, and we all look forward to seeing you back in our real offices, but for now, this is, better than anything that we have. So I'm going to stay on and answer questions. If anybody has any more, I'll try to go through them. And let's see, let me switch back to the camera. Okay, so here's one here. Would you get a thymectomy regardless of what your CT shows? Okay, so the newest data or the most relevant data on thymectomies are that there's a benefit under the age of 60 or 65, depending on what article you read. And so it's always recommended in someone under 60 or 65. Okay, if you have a thymoma, it's recommended regardless of age. But if you do not have a thymoma, the age cutoff is under 60 or 65. I just saw an article, but it was in a small group on patients over the age of 65 that suggested there may be a benefit if you do it early on. But I'm not sure that's not really standard of care. To my knowledge, standard of care is kind of under the age of 60 to 65. Okay, so if you have other questions, reach out on here. I'm able to look at this now. Someone asked if you're on prednisone, is the goal to eventually get you off of it? Okay, so yes, the eventual goal is to get you off of prednisone, but prednisone is fast. And the only fast options we have are either prednisone, IVIG, or plasma exchange. Those are really the fastest options. So if you're newly diagnosed and we are concerned about you acutely, we're going to put you on one or a combination of those options. As I said, other things like Imuran, Cellcept, any other medication you're placed on for myasthenia takes about 8 to 10 months for it to be effective. So we use prednisone as that bridge to kind of carry us over. I have yet to meet a patient who actually likes prednisone. So if you get somebody off prednisone and then you tell them they should go back on it, they look at you like you're crazy. So we all understand that none of you want to be on it. It's people feel miserable on it, but it does work. Any other questions I can answer? So it will be up on our webpage. Let's see. What about possible causes? Is MG associated with any other comorbidities? Yes. So I think actually Lorraine alluded to it in the in the interview that she gave. So there's a definite overlap. As I said, it's an autoimmune disorder. So there's a definite overlap with other autoimmune conditions, specifically, like things like lupus or rheumatoid arthritis or thyroid disease. So there is definitely an overlap among those. And in terms of causes, I think for the most part, it's really thought that the thymus gland is a causative trigger. Why it happens when it happens, I don't think we have a really good answer. But, definitely just an autoimmune thing where the thymus overactivates and you develop antibodies. All right, well, feel free to reach out to me after this. Thank you for taking the time in your lunch break. And again, I really appreciate it's a sensitive time for everybody. So thanks for joining me, and hopefully I provided some sort of entertainment, and hopefully you left here learning something new.